So without further ado, I would love to introduce Dr. John Groot to you. He will be our first speaker today. And let me share a little bit about him with you. He is a professor of neurology and neurosurgery and neuro-oncology, division chief in the Department of Neurosurgery at UCSF. His broad clinical and laboratory experiences enables effective translation of novel therapies into the clinic for the treatment of patients with primary brain tumors. He has significantly contributed to the clinical development of anti-angiogenic, I should know that word, molecularly targeted and immunotherapy treatments for GBM, and he regularly advises companies on such agents in development. He has been the PI, the principal investigator, for over 40 clinical trials, and he's a collaborator on over 80 other studies. Thank you, Dr. Groot. That's amazing. Preclinical collaborations with multiple pharmaceutical companies assisted with the development of drugs for glioblastoma patients, resulting in investigator-initiated clinical trials and influenced larger company-sponsored trials. Thank you. His clinical research efforts are focused on identifying mechanisms of resistance to targeted and immunotherapies. He is developing next-generation trials using novel drug combinations and interventional techniques, including blood-brain disruption using laser ablation and focused ultrasound. I introduce you to Dr. John Groot. Thank you, John.
Well, thank you, Delanne. Thank you so much. And also to the In-Brain Cancer team for inviting myself and Dr. Villanueva-Meyer to present today. It's an honor to be here. I remember, I'm old enough to remember hearing about Chris Elliott back when I was a fellow at MD Anderson. And it's really incredible what you've done over the last 23 years. So congratulations to you and your team. So I'm going to present some updates. Oh, sorry, disclaimer first. So this is non-promotional educational content, and just to let you know that we will not be talking about any agents other than those that are currently under investigational use. These are my conflicts of interest. As mentioned, I do some consulting with various pharmaceutical companies. Okay, so today I'm going to start off with going over an overview and some of the epidemiology, which you're probably all aware of. Talk a little bit about the new WHO grading criteria, some standard of care updates, and then talk a little bit about sort of trying to stoke an immune response in glioblastoma to help improve outcomes. And then I'll hand it over to Dr. Villanueva-Meyer, who's going to talk a little bit more about some of the imaging challenges. And then we'll finish up with a case review to discuss sort of the utilization of this new PET agent to help us guide management and treatment of patients. So everybody's probably well aware of the incidence of primary brain tumors. These are not very common, maybe 12 to 15,000 newly diagnosed glioblastoma every year, compared to 250,000 breast cancer diagnoses every year, for example. But what is very challenging is that this disease hits sort of patients in the prime of their life. And so there's a huge amount of loss of potential life years for these patients diagnosed so early. The clinical presentation, I think this is sort of pretty basic information. Thank you. Obviously, the presenting symptoms are related to where the tumor is actually located and also the rate at which it's growing. There also can be increased edema and intracranial pressure, all of which can lead to things like seizures, focal neurologic symptoms, headache, dizziness, or speech difficulty or weakness, again, depending on the location. So most patients will end up going to an emergency room or to their primary care doctor, who will order a CAT scan usually first, and then this is usually followed with an MRI scan. And as you can see here, these are some of the very typical, but also very rapidly evolving lesions that can result in what we call a ring-enhancing lesion, which we'll talk about more later. So glioblastoma is the imaging sometimes is really almost pathognomonic. really looks like a glioblastoma the first time you see it. And it has to do with that rim of enhancement. It has to do with the surrounding edema, and then sort of this diffuse infiltration throughout the brain. In terms of the next steps, then patients would go either to a biopsy or a surgery. These types of tumors are graded and not staged. You might have heard breast cancer, stage 3A. We don't use staging, we just use grading. Glioblastoma is by definition both IDH wild type and grade 4. There are other lower grade tumors, and we now know these tumors are IDH mutant, and we'll talk a little bit about that. But astrocytomas can be World Health Organization grade 2, 3, or 4, whereas oligodendroglioma are IDH mutant. They are 1p19q co-deleted, but they are only grade 2 or 3. And this is sort of a summary of what I just mentioned. The diagnosis and the pathology reports now are what we call an integrated diagnosis, which was first introduced in 2016 and then sort of further elaborated on in 2021. And this integrated diagnosis includes both the histopathology, so what the pathologist sees under the microscope and the description of that, but also combined with the molecular data. And so it's really critical that any patient who has a brain tumor, that their tissue is actually sent for sequencing for the majority of these sort of important genes that are shown here in the table, IDH1 and IDH2, 1p19q. And then there are a couple of other important ones, such as CDKN2 and CDKN2A and B, homozygous loss, which is a poor prognostic sign, and then the other one being MGMT, methylation status. If you look at the distribution of primary malignant brain tumors, as you see on the bar graph, the pie chart on the right, you see glioblastoma taking up about half of all cases, and then a smaller proportion of anaplastic astrocytoma, which we now call astrocytoma, IDH mutant, WHO grade 3, and then oligodendrogliomas, an even sort of smaller piece of the pie. Median age of diagnosis for the lower grade tumors is around 40, compared to median age of diagnosis for glioblastoma, which is around 65. For all of these tumor types, they are more common in men than in women. The impact of the World Health Organization classification on overall survival is shown in this slide here. The median survival for glioblastoma, we typically put it around 16 months. IDH mutant astrocytoma, grade 4, has a better prognosis, but in between glioblastoma and the lower grade IDH mutant tumors, the top kind of two bars there are the oligodendroglioma, World Health Organization grades 2 and 3, and then the two dotted lines below that are astrocytoma and oligodendroglioma grade 3. So there are, I think, this is a pretty short overall survival curve. It only goes out to 24 months or 2 years, but really to sort of highlight this huge distinction in survival between glioblastoma and grade 4 astrocytoma versus the lower grades. The care for patients with diffuse glioma is really a multidisciplinary team of people who all come together around providing really integrated and comprehensive care for patients with these very complicated tumor types, but also an array of complicated and difficult to manage clinical situations. So not only is the neuro-oncologist heavily involved, but neuroradiologists like Dr. Villanueva Meyer, pathologists, neurosurgeons, psychologists, and also I think it's really critical to point out the important role of social workers, patient support groups, and also caregiver support groups, sort of to take care of the patient and the family. If you look at the known prognostic determinants for outcome, they are age, younger age, obviously performing better. Karnofsky Performance Score, which if you're not familiar with that, I have just a really brief slide on that in the next slide. Females live longer than men do. The extent of resection, with the greater extent of resection, is correlated with better outcome. There's mixed information on clinical trial participation. Some studies suggest that patients do better. Actually, other studies suggest that patients actually do worse. And then, as we mentioned, MGMT promoter methylation status is really critical, with those being methylated, doing much better and responding much better to treatment. And CDKN2A homozygous deletion, which is associated with a worse outcome, particularly in the IDH mutant tumor types. I just wanted to put this up in case people were not familiar with the KPS scale, and just sort of extending from 100, basically being, fully functional, all the way down to, a KPS of 6 to 60, where assistance might be needed, but is able to care for most of their needs, and then sort of decrements below that as shown. So where are we today in 2025 in terms of what we know is effective for the treatment of adult glioblastoma? Maximal safe resection, conventionally fractionated limited field radiotherapy with concurrent daily temozolomide, and then 6 to 12 cycles of adjuvant temozolomide. And then tumor treating fields were approved in 2011 for recurrent disease and 2015 for newly diagnosed disease. There are a couple of more recent updates, which I think have not really changed the standard of care, but there are for some patients. So we know that hypofractionated radiotherapy, so that means sort of a shortened course of radiotherapy. Instead of doing the traditional 6 weeks, it's a 3-week course of radiation, improves survival in elderly patients. We have looked at dose intensification of Temodar, so basically tripling the dose of Temodar given is not associated with improved outcomes. So more is not always beyond 6 cycles of adjuvant was also not associated with improved outcome. There is no difference in recurrent glioblastoma survival for patients who underwent re-irradiation alone or re-irradiation with bevacizumab or Avastin. And then we also, which I'll talk about in a minute, we know there has not been any improvement in outcome with the use of checkpoint inhibitors, these immune checkpoint inhibitors that are approved for many different solid tumors, including melanoma, lung cancer, breast cancer, and various other diseases. So you'll hear quite a bit from Dr. Villanueva-Meyer about some of the treatment challenges that we have, but given that we just sort of discussed radiation and concurrent temozolomide, I wanted to sort of talk about pseudoprogression. I think people all know about this potential phenomenon. Here is an example of a patient who developed radiographic changes 4 weeks after completing radiotherapy, where the contrast-enhancing lesion is, twice as big as it was before radiation. But and then at 8 weeks after radiation, this lesion continues to be large, but then 6 months later, decreases quite dramatically on its own. And this is all without a change in treatment. So there was just adjuvant Temodar given in this patient. There was no other use of any therapy. And this really is something that requires a lot of patience in terms of trying to wait for responses to occur. But also, this is a real challenge. We see this in probably 30 to 40% of our patients, and it's difficult to be in the clinic with a patient showing a lesion that's larger than it was, despite aggressive treatment. And so I think Dr. Villanueva-Meyer will kind of speak to some of the new imaging technology that might help us differentiate and help bring some better clarity in terms of what we're dealing with in these situations. In recurrent glioblastoma, there's actually no standard of care. Re-resection, we do frequently. Probably 20 to 30% of patients will have a second surgery. And this is usually for patients who have good performance and where access to the lesion is easy. Re-irradiation is also commonly done, but has been very difficult to demonstrate an improvement in outcome in randomized trial, in part, I think, because we're really selecting the best patients when we enroll patients for re-irradiation. There are various other chemotherapy options as listed here. And then we always first and foremost, try to identify clinical trials for patients. This is many times limited to first or second recurrence, and prior Avastin exposure is often an exclusion. So just wanted to look at a couple of the recent updates to the field. So, I mentioned molecular testing sort of across all academic centers now, and also with some commercial payers. There are opportunities to do next generation sequencing, looking at genetic alterations across the tumor. And basically, glioblastoma looks very much like other tumor types where you see very specific mutations in targetable lesions in patients with glioma, much like you see in patients with other solid tumors. However, there have been very few drugs that are targeted therapies that have actually sort of met the benchmark for improving outcome for patients. There was a recent study just published a couple of years ago looking at patients with BRAF mutations, both low and high grade tumors, and treated with dabrafenib and trametinib, which is a BRAF and a MEK inhibitor. And as you can see in this table below, there was a really nice number of patients who had response rates, objective response rates for grade 3 tumors, where 40% of patients, and in glioblastoma, 32% of patients had a response rate. And this is very high compared to what you might see with a chemotherapy like lomustine, where you might see 5% of patients actually responding to the therapy. So this is really exciting, and I think this is a really important advance. And this is a patient of mine who had a tumor very deep in the brain, not accessible by surgery. As you can see here, this was a BRAF mutated tumor. And you can see just a couple of months after starting on treatment with the BRAF MEK inhibitor, you can see a really dramatic and a nice response to that treatment. There's been a lot of interest, and you heard from my bio that I've had a long-standing interest in anti-angiogenic therapies. We always thought this would induce blood vessel normalization and allow better drug delivery and improve the efficacy of radiation, as well as potentially alter the tumor immune microenvironment to make this a more treatable tumor. But what we have found is that this can induce really quite dramatic imaging changes. As you see here on the top row, this is before bevacizumab, and then below it, just within 1 month, you can see a dramatic reduction in contrast enhancement. So much like you see pseudoprogression, this is almost like a pseudo response, right? So this is really just due to the drug blocking permeability of the blood vessels and preventing the leakage of contrast enhancement. And we have looked at this drug to see if it improves overall survival, which we, in 2 randomized studies, unfortunately did not improve survival for patients who were randomized to receive standard of care with bevacizumab versus just standard of care alone. So there's a lot of different immunotherapies. I think myself included are really excited about some of the opportunities in immunotherapy. There are some vaccine studies that are ongoing, multiple oncolytic virus studies that are ongoing, but most of the work that we've done has been with immune checkpoint inhibitors, and then sort of a developing field in the CAR T space. So this is a phase 2 study of the Survaxim trial, demonstrating, as you can see in the bottom right-hand curve here, improvement in outcome in patients who had a systemic IgG response to the vaccination. This agent is currently in a randomized phase 2 trial that I think is close to or has already completed accrual, and we're now just waiting to see what the outcomes are between the 2 groups. The most mature data, though, that we have comes from immune checkpoint inhibitors. These are the ones, as you can see on the right, that have been approved in so many different solid tumor types, but as you can see, nothing listed in the brain here yet. There was a clinical trial comparing nivolumab, which is an immune checkpoint inhibitor, versus bevacizumab in patients with recurrent glioblastoma, which unfortunately did not improve the median survival for patients. And then there were 2 randomized phase 3 trials in newly diagnosed patients, one group with unmethylated MGMT, where nivolumab was substituted for temozolomide, and then also a separate trial in MGMT methylated patients, where the nivolumab was added to standard of care of radiation and temozolomide, as well as adjuvant temozolomide. And unfortunately, both of these trials were negative. In both the unmethylated and methylated groups, there was no improvement in overall survival. There's been a lot of excitement around the use of CAR T cells, and this is just demonstrating a couple of studies. These two are from Penn University. Steve Bagley is the first author in both of these studies. The first one looking at infusing CAR T cells into the bloodstream, so intravenously, and they felt like there was no efficacy in a small number in 8 patients with recurrent glioblastoma. However, they used a different CAR T cell that was targeting both EGFR and interleukin-13 receptor, where the CAR T cells were given intrathecally, so into the cerebrospinal fluid space, and they were able to show proliferation of these cells in the cerebrospinal fluid. But unfortunately, we're still waiting to find out if they actually made it into the brain tumor. And then Michelle Manji at Stanford has also been using CAR T cells for some diffuse midline gliomas. Sorry, this slide is a little blurry, but showing radiographic responses as well as improvement in symptoms. And lastly, a group in Boston just recently published this study where they have a very unique CAR T cell that actually secreted a molecule that could actually target factors within the tumor microenvironment. And they were able to demonstrate an improvement or a reduction in contrast enhancement in patients, even within 1 day of treatment. But unfortunately, not shown here on the right is that these tumors did recur relatively quickly. And so I think one thing to note, again, as we emphasize the importance of novel imaging modalities, the checkpoint inhibitors and other immune therapies can really induce some significant imaging alterations. This is an example of a patient treated with pembrolizumab, which is an immune checkpoint inhibitor. And you can see the time course of changes where before treatment, 4 days after treatment, a dramatic increase in contrast enhancement. And then even within 1 week, quite significant increase in the size of the lesion as well as surrounding edema. And it's very difficult to know whether this is actual tumor growth or whether this is pseudoprogression. And I think, this is just a brief slide to just suggest that, imaging as a surrogate, it can be challenging with any immunotherapy and hard to know whether what we're viewing in such a short amount of time is related to the therapy or the immune response to the therapy. So just to summarize briefly before handing off, targeted therapy is challenging. There are very small subgroups of patients who, however, might benefit. We know that, there are probably subsets of patients that are responsive to immunotherapies, and identifying biomarkers for who might respond to such therapy is really important. And then it's really an important feature for us to better understand how to improve delivery and the biodistribution of treatments to brain tumors to help improve their efficacy.
Thank you so much, Dr. Groot. Thank you so much.